Good day. I am Vasileios Minas. I am a consultant obstetrician and gynecologist and a laparoscopic and hysteroscopic surgeon. My NHS appointment is at the St. Peter's Hospital, and it is my pleasure to give this presentation to you today, even though I cannot be among you, as today is the Greek Easter, which comes usually 1 or a couple of weeks after British Easter, and therefore I am with family in Greece. And this had to be a pre-recorded presentation, which I hope works well. And at the end of the presentation, if the connection with Greece works well and our internet here doesn't play up, I'll have the opportunity to talk to you hopefully and answer any questions that you may have arising from this presentation. It is first I'd like to say a few words for this opportunity, as it is truly my honor to be part of Surrey Total Health. This is a remarkable effort from a number of highly skilled consultants, all based locally in the area, an effort to provide healthcare, updates and education to patients, but also the GPs of the area in the and cover the general area of Surrey and possibly west and southwest London. And I'd like to thank our directors, the directors of Surrey Total Health, Dr. Rajib Dutta, who is one of our pain consultants in St. Peter's Hospital and with whom we collaborate very closely at our endometriosis center at St. Peter's, Mr. Shasi Irukula, who is one of our bariatric and upper gastrointestinal surgeons and our divisional director for surgery at St. Peter's Hospital, and Mr. Joshua Jacob and Ashwin Unithan, and who are two of our orthopedic surgeons at St. Peter's Hospital, and have put, particularly Ashwin has put a lot of effort in bringing us all together and organizing the great amount of logistics. I cannot even imagine what he's been through these days to bring everything together and so many different people together to make this event and a lot of events that will follow make them happen. So I'm very grateful to our directors and of course to my colleagues, but above all to you who decided to spend a weekend with us and hear what we have to say, and hopefully leave this weekend a little bit more aware of some of the common health problems and how to look after ourselves better. So I have been tasked with talking to you about some of the common problems in gynecology, and I will cover problems such as ovarian cysts, the uterine fibroids, and endometriosis and pelvic pain. I will talk very briefly and in very general terms about these problems. And I have also some information leaflets for you, which are in this USB stick that I have given to Ashwin with my presentation. You could take from them if you happen to go around on weekends carrying USB sticks with you, or you could contact our center, our telephone center at Surrey Total Health, or my secretary John Jones, and we will email you these information leaflets for the problems that I will talk about today. I will be showing you some illustrations, and during this presentation, unfortunately I cannot pause for questions. We'll have to run it, and then hopefully we'll have some questions and answers at the end. Following my presentation, you will, or you may have already heard from my esteemed colleague, Mr. Ganesh Tyagamuthi, who is a an accomplished and highly trained urogynecologist and consultant obstetrician and gynecologist, and my colleague at St. Peter's Hospital. And hopefully between the two of us we'll cover the basics of gynecological of the problems which of the gynecological problems that a woman may face during her reproductive but also the postmenopausal years. So let's start by talking about ovarian cysts, and before we do that, I'll show you an illustration which should come up now. Excuse for a few pauses while I try to bring the illustrations here as well while I speak, so that I can talk you through them. This is an illustration which shows the female reproductive tract, which is a system which is particularly complex, particularly sensitive to changes. It is regulated by an intricate system of hormones and sub-hormones and various factors which influence each other and the main female hormones themselves, the estrogen and progesterone. And within this complex system, the result of this complex system, when it runs smoothly, is the production of the cycle of the woman. A large part of it takes place here in the ovary, which you can see at the right side of this image, and you can see that as part of a normal ovary, which is what this image shows, there are structures within it which where there are cystic structures within it where the eggs grow and are finally released, ready to be fertilized during the reproductive years of a woman. And I mention this because ovarian cysts are often blamed for a lot of problems, but they're not always responsible for them. And in general terms, we could categorize ovarian cysts in those which are completely harmless and part of the normal ovarian cycle, part of the normal female cycle of the reproductive system. We could then break them down to the cysts which are in lay terms bothersome, and we'll talk about them and when they need treatment, and those cysts which are truly dangerous and are those cysts that could potentially contain cancer cells or turn into cancer and need definite treatment. So the first category of ovarian cysts are the harmless cysts, which are essentially those little cysts which we call follicles, where the eggs grow, and every month there is a number of follicles which are recruited. Only one of them usually will reach full maturation at the middle of the month, and it will rupture to release an egg. And you will see here in this image, which shows the maturation steps in the ovarian cycle, that the oocyte is prepared for ovulation by gradually growing within the ovary, and finally in the middle of the cycle, if all goes smoothly and all these hormones work in coordination and as they should, the ovary is the egg is released, the ovary releases an egg, ovulation occurs, and pregnancy can happen. So these are cysts which usually will come and go. They're part of the normal ovarian cycle. They resolve most of the time by themselves. They may cause some pain occasionally due to slight stretching of the ovary. Occasionally they may have a little bit of bleeding inside, in which case we call them hemorrhagic cysts, from the word hemorrhage, which means to bleed. But if someone is, and again these can cause occasionally pelvic pain, usually to one of the two sides, of the right or the left of the pelvis, where according to on which ovary they have grown. and if one is patient enough and observes them, usually by an ultrasound scan performed 2 or 3 months apart, most of the time they will resolve. They don't reach a size above 1 inch, that is about 3.5 centimeters, and they often, apart from a little bit of pain, they don't cause significant problems. So these are the harmless cysts of the ovary, which are part of the normal ovarian cycle. We'll now talk about a little bit about the bothersome cysts. Now this can be broken down to many different categories with lots of different scientific and medical terms depending on the type of the cyst, the kind of tissue that it contains, and the kind of cells that it originates. They all originate from the ovary, but they can originate from different types of cells coming from the ovary. Now these cysts can usually grow beyond an inch. They can grow to a size of an orange, or even to the size of a football, or even bigger than that, and occupy a large part of the abdomen, rise out of the pelvis and occupy a large part of the abdomen of a woman. Usually these cysts will cause symptoms. They will cause pelvic pain, and occasionally this pain can be described in various ways. It can be a dragging pain, it can be pressure, it can be a sharp pain, it can be a twisting pain, and occasionally, luckily fortunately this is not very frequent, they will cause the ovary to twist around itself, to tort, as we say, and to create an ovarian torsion, which will be acutely painful, has the potential to double up somebody, even someone who's very resilient to pain, double them up with pain, and will usually lead them to the accident and emergency department of the local hospital, where the cyst will be diagnosed, usually by an ultrasound scan, and dealt with an emergency operation. However, still these cysts, which grow beyond the normal size of a follicle, can occasionally be observed once they're diagnosed, particularly when we don't have the suspicion that they may contain cancer cells, because again occasionally they may resolve. However, when they grow beyond 2 inches, so about 6 to 7 centimeters, the recommendation from our Royal College of Obstetrics and Gynecology is to remove them by surgery, and that will usually be by keyhole surgery, a subject which we'll touch upon briefly at the end of this presentation. Your GP will usually refer you for an ultrasound scan if you present with pain, which and symptoms which may sound that you have such a bothersome cyst, as we decided to call them, and will refer you to a gynecology if they find such a cyst in the ultrasound scan. Thereafter, your gynecologist will usually ask you to do a blood test. We have a blood test which is called a tumor marker, called the CA125, which will usually guide the management of this cyst. The result of the blood test and the size of the cyst, together with your desires, will decide. You'll decide together with your gynecologist whether you will observe or whether you have an operation to remove it. Now this summarizes a brief description of those cysts that we've decided to call harmless, and those that we have decided to call bothersome. Now we'll talk briefly about cysts which are truly dangerous, cysts of the ovary, which are the less common to appear, luckily, but they can threaten a woman's life potentially. These are the cysts that can give rise to cancer cells, and cancer of the ovary, which is a condition that, if not picked up early, can be particularly dangerous. The assessment will again depend on the findings that we have from the ultrasound scan, and if there are some suspicious findings on the ultrasound scan and there are specific features which alarm us clinicians about the potential of a cyst not being harmless and not being just a bothersome cyst, but being a truly possibly dangerous cyst, there are specific features on the ultrasound scan. This will lead us to request an urgent blood test, again the CA125, as we said, and an urgent further scan, which will usually be an MRI or a CT scan, which are more detailed scans. It will give us some more information not only about the cyst but also the tissues around it and in the pelvis and in the abdomen. And if the suspicion of when all this information is put together, there is a level of suspicion of potential malignancy, and that can be low, in which case again we may decide to do conservative management, or the level of suspicion may be moderate or high, in which cases the management will usually be by surgery. One thing that we should mention is that particularly during the reproductive years of a woman's life, so before menopause, it is almost always, when dealing with a bothersome cyst, it is almost always for a skilled laparoscopic surgeon to remove the cyst only and not the ovary itself. And that is a very important point, because a lot of patients who present with ovarian cysts worry about the potential of losing an ovary as a result of the cyst. This is rarely the case. Patients may also worry often about the potential of their hormones, their hormonal status changing following treatment for a cyst. That again is rarely the case. In most of the times, most of the cases, we're able to salvage, to save the ovary, to keep the normal ovarian tissue behind, while separating the abnormal cyst and removing it and leaving the ovary behind to heal. And ovaries do heal very well if the surgery is performed appropriately. They heal with little problems in the future. Of course, ovarian cysts is a problem which can recur, and it will recur, as we said, as part of the normal hormonal cycle of a woman. They can appear after menopause as well, and even if you've had surgery in the past for an ovarian cyst, each new cyst that appears merits its own assessment and decision of how to manage it. So I hope that this concludes some basic information about ovarian cysts, and we will carry on with another type of lumps that we can find, another type of masses that we can find in the reproductive system very commonly, the fibroids. And I will show you an illustration of fibroids. Fibroids, again, we could probably again categorize them to harmless fibroids, which can occur very frequently. Approximately one every 5 women will have some type of fibroid, even though they don't know it, as most of the time they don't cause any symptoms, they don't cause any problems. They are not like the harmless ovarian cysts, in the sense that they are not part of the normal cycle of the reproductive system. They are not normal tissue, they shouldn't normally be there, but they can be harmless, completely harmless if they are small, if they are usually up to an inch or even smaller. They will often cause no problems at all, and unless someone has an ultrasound scan for a different reason, many women will live all their lives without even knowing that they've had small fibroids. So this image, this illustration shows you the various types of fibroids. They arise from the muscle fibers of the uterus, and as we said, they can be as tiny as half a centimeter, or again they can grow to a really large size, outgrowing the uterus sometimes, which is usually the time that they cause problems such as pain, pressure, and heavy periods depending on their position, a subject that my colleague Mr. Tiagamothi will talk to you about. So looking at this illustration and starting from the top to the bottom, you can see the various types of fibroids, and there are three main types. At the top you can see what we call an intramural fibroid, and that is in that pink area of the uterus in this illustration, which represents the muscle of the uterus, the uterine muscle. Then the fibroid below that is a pedunculated submucosal fibroid, and mucosa is the name that we give to the endometrium, the tissue that lines the inside of the uterus, and that is a little bit darker pink that you can see inside the uterus lining the cavity. These are the types of fibroids that, because they protrude inside the uterine cavity, they can cause problems such as heavy periods and infertility. Other fibroids which do not distort the uterine cavity, like the intramural fibroids, or the ones that you can see a bit lower, the subserosal fibroids. These fibroids, they live either in the muscle of the womb, as we said, or just below the outer surface, the serosa, as we call it, of the uterus. These fibroids usually, if they stay to a reasonable size, less than 1 or 2 inches, they will rarely cause problems, they will not cause heavy periods, and they will probably not cause difficulty becoming pregnant. However, it is these fibroids which have the tendency to grow to a significant size, and in these cases they will cause pain and pressure, and often they require removal. Again, the decision of what to do with a fibroid, whether to leave it, and if it's particularly small, it doesn't even need observation with ultrasound scans. One ultrasound scan showing 1 or 2 very small fibroids up to 1 to 2 centimeters in size does not necessarily need to be repeated, unless you are worried about something in particular or you have some new symptoms. Larger fibroids, we may tend to observe them every few months or every year with an ultrasound scan if the patient decides not to have them treated. And those which cause problems like infertility or heavy periods, and as we said, these are usually the submucosal fibroids, we will usually treat them either with medication, which can help shrink the fibroid, or if the medication cause unacceptable side effects or are not a desirable or desired form of treatment, then the other option will be surgery. Now, the type of surgery that we will perform for a fibroid again will depend on its size and its position. If it is a fibroid that protrudes inside the cavity of the uterus, like the submucosal fibroids that we talked about, then the surgery will be done from the vaginal route, and it is called a hysteroscopy. It does not involve any cuts in the abdomen, and it is done through we pass a camera and an instrument through the vagina, through the normal opening of the cervix. We fill the cavity of the uterus with water, we have a look inside, and we remove the fibroids. If the fibroid is on the outer surface of the uterus, a subserosal fibroid, then we cannot reach that via a hysteroscopy, and we will prefer to do a laparoscopy, where instruments will be inserted in the abdomen, and if it is within a certain size, we will be able, most of the time, again, in the hands of a skilled laparoscopic surgeon, we will be able to remove even significant size fibroids through little very little cuts in a patient's abdomen, and this is what we call laparoscopic surgery. It is important to remember that having fibroids should not cause massive concern. It should cause enough concern to investigate them and get an opinion from a specialist about what to do with them. But it is rarely a kind of problem that will turn into something seriously and life-threatening. So they will very, very rarely turn into cancer. It is possible. It is called sarcoma, uterine sarcoma, the type of cancer that these fibroids can give rise to, but it is a very rare form of cancer, and we would very rarely operate fibroids or advise to have them removed just because of that risk. We will usually advise to have something done about them, to have them treated if they cause symptoms, and not because of their potential risk of turning into cancer. That concludes. I'll talk about fibroids. I have one more illustration here to show you, which shows the picture that we get during a hysteroscopy when we have a look inside the uterine cavity from the vaginal route and through the cervix. This shows a normal cavity which looks smooth and clear, and this illustration shows this picture. It's not an illustration, actually it's a picture from a normal patient, from a human, it's not a drawn picture, it's a live photograph. Shows a cavity with a fibroid, which you can see at the top. It is a submucosal fibroid. It's a type of fibroid that protrudes into the cavity of the uterus, and these are the type of fibroids that can cause infertility and heavy periods, and we usually treat with the hysteroscopic approach, the approach through the vagina and through the cervix. Now we will touch on the subject of endometriosis, and endometriosis is one of these conditions that do not get a lot of publicity, but they can disrupt severely a woman's life and the life of the partners, and in particular of the whole family, as they cause a number of symptoms, which are all usually most of these symptoms are around the pelvis. They are pelvic, painful symptoms, and they can be and these can be various types of pains, like pain during periods, pain throughout the cycle, pain which follows a cyclical manner, a cyclical pattern, follows the monthly cycle of the woman, pain while opening bowels, particularly during the periods, and painful intercourse. And that is why it is a subject that can affect significantly a woman's life. It is usually a problem during the reproductive years of the woman, and less commonly a problem that appears or becomes bothersome in the menopausal during menopausal life. The nature of the problem is, the reason of the problem is that a kind of tissue which we call endometriotic tissue, which is very similar to the endometrium, which is the tissue that lines the inside of the uterus, of the uterine cavity. This kind of tissue grows outside the uterus, outside the uterine cavity, most of the time inside the pelvis, and it can attach itself to and grow itself onto various areas inside the woman's pelvis, and it responds to the monthly hormonal cycle in a similar manner to that the endometrium does, the normal lining of the uterus, and therefore every month it bleeds, and it causes an inflammatory response inside the pelvis, which causes all these symptoms, all these painful symptoms, plus occasionally or frequently it can cause infertility, it can cause problems, difficulty becoming pregnant. And I do have an illustration here, a couple of illustrations which show, this shows the various areas where the endometriosis, which is the brown, dark brown tissue shown in this illustration, can attach itself. As you can see, it can attach on the fallopian tubes, on the ovaries, or outside the uterus, on ligaments which surround the uterus and hold the uterus in position, and it causes pain as it follows the hormonal pattern of the woman and responds to it. A second illustration here, taken from the side, again the brown black tissue, and the whitish lines show adhesions. It shows that one of the effects of the tissue of the endometriosis is that it creates adhesions between different organs. So here in the middle with the pink we have the uterus. In front of the uterus is the urinary bladder, and you can see that endometriosis on the bladder can cause adhesions between the uterus and the bladder. On the right of the image we have the bowel, and again endometriosis between the uterus and the bowel can cause adhesions between these two organs, and the adhesions are one of the reasons that the condition is painful, and it's also quite challenging from a surgical point of view to deal with it. I have a video to show you about endometriosis, which I have taken from the webmd.com website. It's a lot of the information on this website is free. It's a short video, and it's very nicely made. It may give you a little bit more understanding about the nature of the conditions. I will let it play now.
Endometriosis happens when the tissue that normally grows inside your uterus grows outside of it instead. This misplaced tissue often attaches itself to the ovaries, fallopian tubes, bowel, or bladder. It can spread to other internal organs as well. Just like the lining of the uterus thickens and bleeds each month during menstruation, so does the tissue that forms outside the uterus. But because the bleeding happens in areas where it can't easily leave the body, it causes inflammation and swelling. Women with severe endometriosis may have heavy and painful menstrual cycles, and sometimes may also have problems getting pregnant. The fallopian tubes can become blocked by endometrial tissue. See a doctor to get a diagnosis and to learn about treatments that can help.
So, endometriosis is a challenging condition to deal with. It should be dealt with by the appropriate specialists. At St. Peter's Hospital, we have set up one of the largest endometriosis centers in the United Kingdom, and with my highly esteemed colleague, Mr. Shihin Kazali, we manage a large number of women with endometriosis and severe endometriosis every year. If you have it's important to note, however, that a lot of the symptoms of endometriosis can occur without having the condition, without having endometriosis at all, and therefore one should not jump into assumptions or conclusions, but should have the appropriate investigations, which will usually include an ultrasound scan and an examination by a specialist, and have and then following that be referred to the appropriate to an appropriate endometriosis clinician. The management can be by medication, starting from simple pain relief to hormonal contraception, which is a recognized treatment for endometriosis and often can be enough to control the symptoms. And the most invasive approach will be surgery, where in the vast majority of cases will be performed via laparoscopic, by the keyhole route, and we'll aim to excise, to remove the endometriotic tissue, the abnormal tissue, and keep the normal tissue behind. And in women of reproductive years who want to have not completed a family, this will mean that the surgery will aim to excise, as we say, to peel off, to treat the endometriosis, but of course to spare, to preserve the uterus, the fallopian tubes often, and of course the ovaries. Occasionally, a hysterectomy may accompany, removing the uterus may accompany such an operation for endometriosis, but it is not the rule. The rule is, the common method is to peel off the endometriosis surgically by keeping the organs that need to be kept inside. And finally, I would like to show you an illustration of what laparoscopic surgery looks like. Here you can see a surgeon. It is performing an illustration of a surgeon performing laparoscopic surgery. The patient will always be under general anesthetic, and there will be a specific and a very carefully designed setup in theatre to make it possible to perform laparoscopic surgery or minimally invasive surgery in general, and that will include the appropriate instruments, surgical instruments, but also a stack which will include a monitor through which the surgeon sees inside the patient's abdomen. And laparoscopic surgery has been developed over the last, has taken off over the last 10 to 20 years, and it's one of these advances which have revolutionized the care that we provide to our patients, as we can perform most of surgical procedures through that, and the result is less pain, less bleeding, less infections, and quicker recovery compared to the old way, which was the open surgery, which we used to do more frequently until 20 years ago. So this concludes my presentation. I hope I haven't tired you, and that we've covered a few basic gynecological problems. You will hear more. You may have heard already from my colleague, Mr. Tiagamurthy. It's been a pleasure that I had this opportunity. Thank you for honoring us with your presence today, and we hope that we'll see you in future events that Surrey Total Health will organize. So we look forward to seeing you again in the future. Take care of yourselves.